systematic review and meta-analysis. For the clinical case scenario, let's consider we have two patients in our OPD. One is a 60-year-old male who was a diabetic for 20 years on oral anti-diabetic medications. This patient is on semaglutide from outside, as he was told that it would reduce his risk of having a heart attack. His HbA1c is 8%, he is already on maximum dose of metformin and glucagon-like. We have another patient, a 54-year-old, who was a diabetic for the past 10 years. He is on metformin and thrice daily atrapid for sugar control with the HbA1c of 9%. The question we have is, we have read that SGLT2 and GLP1 agonists, SGLT2 inhibitors and GLP1 agonists help in reducing cardiovascular risk and CKD progression. We have one patient who is already on a GLP1 agonist and the other patient is not on. We want to know whether we should start SGLT2 in both these group of patients. Will the effects be differential across both these group of patients, or will it be independent of the GLP1 use? For this, we looked at this meta-analysis, looking at efficacy and safety of SGLT2 inhibitors with and without GLP1 receptor agonists. It's a SMART C collaborative meta-analysis of randomized controlled trials. For this, we'll be using the grade approach. Just a word on this approach. First, we will have to, our initial rating of confidence will be based on what study designs they have chosen. For this, we are looking at effects of SGLT2 and looking at its outcomes. So, for that, we would like to have randomized controlled trials. We will also subsequently look at the risk of bias, inconsistency, that is the heterogeneity among the trials, indirectness, which looks at what patient population was studied and what we are applying this trial to. We look at imprecision, which is the confidence intervals, the sample size in each of these trials, and publication bias, which we assess with a funnel plot. Coming to the first question, is the basic study design valid for a systematic review? So, did the systematic review address a clearly formulated question? So, here the population that we want to look at was adults. They looked at adults aged more than 18 years with diabetes, with or at a high risk for ACVD. They looked at heart failure and CKD, and they have looked at patients with and without GLP1 receptor agonists at baseline. So they have looked at three groups of patients. One is diabetics with or at a high risk for ACVD, heart failure and CKD patients among these trials. And the intervention was SGLT2 inhibitor, the comparator was placebo. The timeline was more than or equal to 6 months. And the outcome, I have just put what they have defined as high risk of cardiovascular events. We have looked at other trials and put this up. What they took as CKD and high risk of cardiovascular events. The outcome was cardiovascular one and kidney the second one. Cardiovascular mainly major adverse cardiovascular events. That is a composite of non-fatal myocardial infarction, non-fatal stroke or cardiovascular death, and hospitalization for heart failure or cardiovascular death. This is the cardiovascular outcome they looked at. They also looked at a kidney outcome, which was a composite kidney outcome, looking at decline in EGFR or the glomerular filtration rate, and the kidney failure, which they defined as a more than 40% decline in EGFR, kidney failure, which they defined as an EGFR of less than 15, chronic dialysis or kidney transplantation or death due to kidney failure. They've also looked at the rate of change in EGFR, which they have plotted as an EGFR slope. So these were the outcomes that they looked at, whether SGLT2 inhibitors in our population among the people with baseline GLP1 use and without baseline GLP1 use had a benefit on cardiovascular and kidney outcomes. Did the researchers search for appropriate study designs to answer this research question? So since we're looking at the effect of a particular drug on cardiovascular and kidney outcomes, we would like to have randomized controlled trials, and they've correctly chosen randomized controlled trials in this meta-analysis. They've chosen 12 trials which were part of this consortium, which was the SGLT2 inhibitor meta-analysis cardiorenal trialist consortium, and they've restricted it to analysis cohort was exclusively enrolling participants with diabetes among these three populations. First population is diabetics with or at a high risk for ACVD, heart failure and CKD. So among these 12 trials, they have taken these diabetic population and classified them into these three groups. These were the individual 12 trials, and totally there were 70,000 patients with diabetes and around 3,000 were receiving a GLP1 receptor agonist at baseline. The rest did not have GLP1 agonists. So there is a difference. I mean, among 70,000, only 3,000 had GLP1 agonist use, while the rest were not using a GLP1 agonist. is the systematic review methodologically sound? For this we will look at whether all important relevant primary research studies were included in the systematic review. In this systematic review and meta-analysis, they have not by themselves looked at, gone through databases to get the trials. They have looked at these two systematic reviews. One is the SGLT2 inhibitors and major adverse cardiovascular outcomes. The other one is impact of diabetes on the effects of SGLT2 inhibitors on kidney outcomes. From these two systematic reviews, they have taken the trials. One had 13 trials, the other had 11 trials, and they have taken 12 out of these trials and used it for their meta-analysis. The authors, however, were overlapping among all these systematic reviews. The search strategies also have been as what they have mentioned for the other systematic reviews. So what is the SMART-C consortium? It comprised of all randomized, double-blinded, placebo-controlled, event-driven outcome trials, which evaluated the effects of SGLT2 on multiple outcomes. So this search strategy that I have written is what they used for the CKD systematic review. They looked at Medline and Embase. There was no language restriction, and they looked at primary trial publications and peer-reviewed publications. They have not looked at unpublished studies or ongoing trials. Again, how they screened the studies is all based on what they looked at for the CKD systematic review. The titles and abstracts were initially screened by an author. Subsequent screening and risk of bias assessments were independently done by two authors, and conflicts were resolved by consensus discussion. So we know that there are 12 trials in this. In the CKD systematic review, there were 13 trials. So this was the trial that was excluded, the soloist HF trial, and they excluded it for a reason that they were followed up for a short duration. So they could not assess effects on CKD progression. We'll come to what the screening criteria was in the subsequent slide. So this was the screening criteria that they used to include patients in this meta-analysis. They needed more than or equal to 500 participants in each group, and they wanted a duration of more than or equal to 6 months. So this would essentially exclude smaller trials, which may not be very good for our systematic review and meta-analysis, since they've said that they need more than 500 participants in each group. So they've looked at only fairly large trials in this meta-analysis. These were the 12 trials that they looked at. Coming to whether they've summarized the search and its outputs. So essentially we're looking at a Prisma type flowchart, which was again not provided for this meta-analysis. So I've taken the Prisma charts from the other two systematic reviews. One is the CKD progression, the other one is the cardiovascular outcomes. However, it's important to note that they have not done a Prisma or a risk of bias for this meta-analysis per se. So we can see that this was a CKD progression. They've looked at Medline and Embase. After removing duplicates, they've screened 2,118 trials, and full text reviews were 492. And ultimately the total records identified were 257, and the trials that were included were 13 trials in the CKD, while in the cardiovascular systematic review were 11 trials. They've taken, except for the soloist HF trial, they've taken all the other 12 trials in this meta-analysis. Coming to the risk of bias, did they assess the validity or methodological rigor of the primary research studies included in the systematic review? Again, risk of bias was not provided for this meta-analysis. These are the risk of bias of the two other systematic reviews. But we cannot take this to be the risk of bias for our study, because the outcomes that they assessed in this cardiovascular and CKD are not accurately applicable to our meta-analysis, to the outcomes that were applicable for our. So, but if we are looking at the bias table, if we ballpark it, we can see that overall the studies had a low risk of bias. So in the risk of bias table, we will look at whether they were randomized, allocation sequence concealment, blinding of participants and outcome assessors, and reporting. And based on the strengths of how they've done these in individual trials, we assess, we attribute whether they are at low risk of bias, or whether there are some concerns, or whether they are at high risk of bias. So if we look at this risk of bias table from those two systematic reviews, they are all at low risk of bias. Did the researchers extract and present information? Again, details of extraction of data in this meta-analysis is not given clearly, but they have mentioned that they were investigators from each trial were present and they analyzed the treatment effects and safety events within each trial using individual participant data. So rather than taking the results from each study, they have looked at the individual patient data as well. They have also given forest plots, but not for each individual trial. They have grouped trials together into diabetics with risk of ASCVD, CKD trials and heart failure trials, and given forest plots for each of these groups. So just a table on the baseline characteristics. So we can see that they have grouped the trials into diabetics at high risk for ASCVD, CKD trials and heart failure trials. And in these we can see the participants. They have grouped the patients in these trials further into patients who had GLP-1 receptor agonist use and patients who did not have GLP-1 receptor agonist use. So all these patients were diabetics. They have taken only diabetics in all these trials and they have grouped them into patients who had GLP-1 RA use and who did not. Further, they have subclassified this into patients who were using GLP-1 agonists, whether they were using, they divided it such that one was the placebo group and the other was having SGLT2. Similarly, they divided the other group which did not have GLP-1 RA into SGLT2 inhibitors and placebo. One striking feature is that we can see among the GLP-1 receptor agonist use group, the number of people were 937 and 693. But in the other group, there were 23,000 and 717,000. So there was quite a difference between the patient population who were using GLP-1 receptor agonists. Since we assume that randomization, we have seen in the risk of bias table that randomization was adequate for each of the individual trials, we don't necessarily need to go and assess the baseline characteristics in this table that they have given. So we assume that it would have been matched. This is again just a table where they have given the results for each trial per se. So again, we can see that they have classified the entire population into baseline use of GLP-1 RA and no baseline use of GLP-1 RA. In that, they have subclassified into SGLT2 inhibitor usage and placebo group. And then this is for major adverse cardiovascular events and this is for CKD progression. The results they have given for each of the trials and put it as hazard ratios. But we'll go into the forest plots. We won't go into this graph per se. So before we come to the results, should we trust the results of this trial? So we've seen that they have not done literature search for this meta-analysis per se. They have not put a PRISMA flowchart or a risk of bias table for this trial. So we should consider all these while looking at the results of this meta-analysis. So did the researchers analyze the pooled results of the individual primary research studies? Coming to this, they have mentioned that power calculation has not been done. But the power calculation essentially means that if they were to do a single large randomized controlled trial, would the number of patients in this meta-analysis be less than a single large randomized controlled trial? We've seen that the number of patients in this meta-analysis is 70,000. So they have taken there are adequate number of patients in this meta-analysis. Now the significance of heterogeneity they have assessed by p-values. This is derived from the chi-square test. They have not used I-square statistic, they have used a p-value. So if the p-value comes as significant, then that means that there is significant heterogeneity between the trials. But if the p-value is not significant, that means that the variability could be random error. That means we can trust the results. They have used a random effects model and hazard ratios have been given with confidence intervals. But they have not provided a funnel plot, which we would have liked to know publication bias. So just a word on the statistical methods that they used. They used a two-stage meta-analysis. They used Cox regression models. They have given the hazard ratios, log transformed hazard and risk ratios, and they've used a mixed effects model for the EGFR slope. Coming to the results. So first result that we want to see is effect of SGLT2 inhibitors on major adverse cardiovascular outcomes. So if we can see that they have grouped them into baseline use of GLP-1 RA and no baseline use of GLP-1 RA. Here we are looking at major adverse cardiovascular events. The percentage of patients, so these were the trials that they grouped them into. One is diabetics with high ASCVD, the other one is stable heart failure, the third one is CKD. We can see that the percentage of patients in the heart failure trials were more in both the groups, 12.8%, 13.6% as compared to the others. And that makes sense since we are looking at the cardiovascular outcomes. Now looking at this forest plot, these are the grouping of patients who used baseline GLP-1 RA. And we can see that they were fairly small trials. They used, small trials as compared to the other one. Here the total number of people were 937, but here the total number of people were 23,000, which is also reflected in the confidence intervals and the point estimates. So since the trials are small in number, the point estimates are also small as compared to this where the point estimate is quite big. And the confidence intervals are also big since the number of patients in this particular trial was only 88, which is why the confidence intervals are quite wide. But here the number of patients were 23,000, so the confidence interval is very small. And they have given subtotal effects for each group. So this is the subtotal of the patients who were using baseline GLP-1 RA. And we can see that this is crossing the line of no effect with the hazard ratio from 0.63 to 1.03. While in this group, the patients who did not have baseline use of GLP-1 RA, the subtotal effect is between 0.86 to 0.94. That is, it's not crossing the line of no effect. And essentially this subtotal effect is driven by this large RCT because that is using 23,000 patients and that has been the trial which has pushed this subtotal effect to the side, which favors SGLT2 inhibitors. So the total of both these groups has also shown benefit with a hazard ratio of 0.85 to 0.94. But we should remember that if we look at the subgroup of patients who use GLP-1 RA, it was crossing 1. So SGLT2 inhibitors on major adverse cardiovascular events, they have written that in the total population there is a use, whether there was baseline GLP-1 RA use or whether there was no baseline GLP-1 RA use. But if we look into each subgroup, we know that the effect was more in the patients who did not use GLP-1 RA. That was mainly because of this large trial which looked at patients with ASCVD. So whether it will be beneficial for stable heart failure, again this was crossing the line of no effect. So more benefit for diabetics who had high ASCVD. Now we are looking at CKD progression, effects of SGLT2. Again, the forest plot shows these were the subtotal effects and this was the total effect. Again, the confidence intervals were wider in the GLP-1 RA group and the point estimates were lower, and the subtotal effect of the GLP-1 RA group was nearing 1. Here it's 0.94. So it was to one side, but it was nearing 1. While in the patients who did not use baseline GLP-1 RA, they had large point estimates, fairly small confidence intervals, and the effects were all favoring SGLT2 inhibitors. So SGLT2 inhibitors had a beneficial effect on CKD progression, more for the patients who are not using GLP-1 RAs. Coming to all-cause mortality, in this again we can see that the trials in patients who are using GLP-1 RA, they have mentioned in their results that SGLT2 inhibitors have a beneficial effect on mortality regardless of whether patients were using GLP-1 RA. But we can see that in the subtotal of the patients who are using GLP-1 RA, it was crossing the line of no effect. So but in the other group where patients were not using GLP-1 RA, there was an effect which was on one side. So we may have to use it only in this population. We cannot extend it to the people who were using GLP-1 RA agonists at baseline. Coming to the other outcomes that they've looked at, hospitalization for heart failure or cardiovascular death, all showed a beneficial effect for SGLT2 inhibitors, mainly for the patients who are not using GLP-1 RA. This is hospitalization for heart failure and cardiovascular death, all of which the total was favoring SGLT2 inhibitors. Now this is the chronic EGFR and the total EGFR slope. So the total EGFR slope means the EGFR that they calculated at randomization, and chronic means from the first visit. or when treatment was started. So we have to EGFR as it falls, as the fall of the EGFR is more, that means the outcome is worse. So in placebo we can see that the rate of fall of EGFR was more than in the SGLT2 inhibitors. So that means SGLT2 inhibitors had a lesser decline in kidney function over time, and it benefited patients. Even if you look at the absolute difference or the relative difference, the relative difference was 57%. So there was that much of a reduction in the rate of fall of the kidney of the glomerular filtration rate. Coming to adverse events, again they've divided it into two groups: patients using GLP-1 RA and not, and the total effect was favoring SGLT2 inhibitors. This was again not what we usually see, because we are adding another drug. We would expect some adverse events, but they've shown that the population that used the drug had less adverse events, less serious adverse events, with the hazard ratio between 0.89 to 0.93. So this was with regards to adverse events. Now coming to limitations, we have already seen that they have not done a search in this meta-analysis of the databases. They have not put the PRISMA and the risk of bias tables in this meta-analysis. Those are all limitations. Again, we have seen that the number of patients in the GLP-1 RA group was less than the number of patients in the other group. Only 3,000 in the GLP-1 RA, while the rest 67,000 were in the patients who are not using. They have also grouped all GLP-1 RA together. So they have not accounted for class differences. They have also not mentioned what was the GLP-1 RA that they were using. And they have, here we have looked at patients who are already on GLP-1 RA, not patients who are initiated on GLP-1 RA. So again, we cannot assume that initiation of both SGLT2 and GLP-1 RA can give effects similar to what we see in this meta-analysis. They have also not provided a funnel plot. So just to explain what the funnel plot is, this is not what is provided here. I just put this picture to explain. So essentially, funnel plot is what we use to see if there is any publication bias. This is the overall effect, the center line, and this is the 95% confidence interval. Larger trials, which we expect to contribute more to the overall effect, will be closer to the midline, and they will be also higher up, as they will be more precise. While the smaller trials, which have wider confidence intervals, as we've seen in the forest plot, will be scattered at the baseline. So all the studies that we look should have an even distribution on either side of the overall effect. In certain cases, there may be larger studies who contribute to this, but all the smaller studies may be on one side of the overall effect. That is not they have not taken an adequate representation. We cannot say that all the studies contribute to the overall effect. So they have not provided a funnel plot, so we are not able to assess the publication bias. Are the results of the systematic review relevant locally? So if we see the baseline population that they put in this were fairly similar to us. The age of these patients were around 63, except for the BMI, where they were all more than 30. We don't see that much of a high BMI patients in our practice. But all the other characteristics like history of heart failure were around 18-20%, and all the other characteristics are fairly matched, and we see these kind of patients in our OPD as well. So the baseline population is fairly similar, but however, our patients are rarely on GLP-1 agonists. We do not routinely use them. Here we have, however, seen that SGLT2 inhibitors had effects on cardiovascular and renal outcomes, which is independent of GLP-1 RA. And they have also studied other relevant outcomes like all-cause mortality and serious adverse events on starting this. So will the implementation represent a greater value for our population? We can see that if they were applied to our local population, here we have seen that SGLT2 inhibitors showed better cardiovascular and renal outcomes in diabetic patients, regardless of whether they were on GLP-1 use. And they have also mentioned that adverse events were less in the SGLT2 inhibitor group. Would it add any additional value for the patients? The cost of 10 mg of dapagliflozin, which they have used in most of the trials, is 10 mg, is 13.5. The cost for a month will come to 480. Now, if we were to look at all-cause mortality, this is ideally hazard ratios, if we equate it to a relative risk, 93% is the upper limit. That means there could be a 7% reduction, relative risk reduction in mortality. It's not absolute reduction. So we should know the baseline mortality of our population without SGLT2 inhibitor use. Let's say for mortality is around 10%. That means 7% of 10% would be the reduction. That is 0.7. So 9.3 will be the mortality with SGLT2 inhibitor use. So for a 0.7 reduction to have an effect, the number needed to treat would be 100 by 0.7, which will come to around 143. So that many patients we should treat to have an effect, assuming that the mortality without is 10%. So we should remember that those are not absolute risk, it's only a relative. So coming to our initial question, will we use this to guide our decision making? Our initial question of 2 patients who had an SGLT2 inhibitor use who had a GLP-1 RA drug at baseline and put it to who are diabetics. We have seen the methodological rigor that they have applied and the results. So I would use it since they have these trials have been used in other systematic reviews. They have a large patient population, and the benefit, however, is, I would say, restricted to patients who did not have GLP-1 RA use at baseline, because the subgroup of the patients who were using it crossed the line of no effect. So I would consider it in the patient who is not on GLP-1 RA.